Good afternoon, everyone. How's everybody doing? Good. All right. So my name is Julia Edwards. I have been a registered nurse for over 15 years. I began my career as a complex med-surg nurse as well as orthopedics. And then 7 years into my career, I transitioned to case management. I've been a certified case manager for over 8 years, and right now I currently lead a team in Georgia. We're responsible for all of the practice under Village Medical's case management programs within Georgia. So that includes nurses, social workers, care coordinators, the list goes on. So I'm here to talk about the care plan blueprint. And by looking at the time and some of your faces, the most important blueprint many of you are focusing on is the floor plan to lunch. So I will make sure we'll get there on time. But I wanted to close out the morning with this topic because conferences are very good at talking about strategy, but what I often leave craving more of is what it looks like when these strategies collides with reality on Monday morning. So the hardest part of change isn't really learning the new process, it's learning how to keep adapting when the process changes again. So I want to tell you about a time that I was truly frustrated. Well, honestly, I was pissed off. It was when I transitioned from inpatient to telephonic case management. Now, understand that there are some connotations that may make this seem simple. However, you're using different senses differently. Whereas inpatient, you have the patient in front of you. You can see the edema, you can hear the crackles, you can, pretty much sense what's going on. Telephonically, strictly auditory. So now you have to change how you assess, how to ask those questions that you would normally visualize or auscultate. So, as you can imagine, that journey was a little bit cumbersome. But the most difficult aspect of it was the documentation. You're looking at a screen, a bunch of fields, somehow, some way, you have to make this a coherent clinical picture. Hard enough, but I did the work. Finally climbed that mountain, and guess what? They changed it. New workflows, just new everything. And it was uncomfortable. It was humbling, but there were days where I really was sitting behind the cursor and just thinking, what did I get myself into? But I did the work, I learned it, found the confidence, efficiency, and it was at that moment where I began to realize that this frustration wasn't necessarily geared towards learning the new process per se, it was having to do this all over again. But in the value-based care world, the rules will always keep evolving. And if we tie our confidence into finally figuring it out, we'll always feel left behind. So the real skill, the one that matters most, isn't learning the process, but adapting. So today we're going to talk about the good, the bad, and yes, the ugly of leading change in healthcare and how we move from absorbing change to finally leading it. So before we talk about change management, I want to briefly discuss value-based care and why change can feel so difficult. At its core, value-based care represents a shift in how we define success, from volume to value, from doing more to achieving better outcomes, higher quality, and managing the total cost of care. But this is not just a payment reform, it's how care is coordinated, measured, and supported across systems. And that's what makes it one of the most significant and underestimated change management challenges in modern healthcare. At the leadership level, value-based care often makes sense. Clear goals, well-designed models, smart people building thoughtful frameworks, but success doesn't happen at the strategy table. It happens at the front line. Nursing leadership matters because nurses sit at the intersection of clinical care and patient advocacy and operational execution. We are the ones translating vision into practice, navigating legacy systems, and evolving roles, fragmented workflows, and mismatched metrics. And too often, frontline teams are asked to execute new models inside old systems, and that's the gap. So on the front line, it's not clean. Systems do not talk to each other. Metrics don't necessarily align with reality, and roles quietly expand without clear boundaries. That frustration isn't about one change. It's what happens when systems evolve and people are expected to evolve even faster. So our question today is simple, but not easy. And how do we close the gap? How do we support the ones living it? And how do we move from reacting to change to finally leading it? Now, one of the most useful ways to understand this comes from the authors of Switch, Dan and Chip Heath. I had the luxury of recently completing my executive MBA, and this was one of the books that we learned about in one of our classes. The book describes the writer and the elephant framework. So the writer is the rational mind. They're the ones who understands the logic, the workflow, the protocols, things of that nature. Then you have the elephant, which is our emotional side. They're the ones who understand the empathy, the compassion, the ones that's shaping that experience with trust and meaning. When these two are aligned, change works beautifully. However, when they're not aligned, you often hit brick walls, bottlenecks, different types of challenges. So in healthcare today, nurse clinicians are experiencing burnout or role ambiguity and acting as buffers in some systems. And in those environments, the writer is confused and the elephant is exhausted. So here, let's talk about the unified change framework. And this comes directly from the framework that I just mentioned, as well as the framework of John Kotter, which is 8 steps of change. And in this concept, we're looking at the first phase, directing the writer, and what that looks like, creating that sense of urgency, building that coalition, and forming a strategic vision. The next phase is looking at the elephant, and this is where we're enlisting a volunteer army, enabling action by removing barriers. And then the biggest portion of this journey is shaping the path. And this is where we're generating these short-term wins, sustaining acceleration, as well as instituting change overall. Directing the writer is about clarity, and it's helping people understand the logic, the why, and the where we're going. That's where change agents come into play. They're the ones who are helping the people understand what's driving this transformation forward and creating that direction and connecting strategy to action. Then we have that motivating the elephant piece, and that's tapping into the purpose, that trust, and that emotions. And that's where champions really shine in this area. They keep the purpose alive, translating that vision and energizing the team and others when things get tough. And then as leaders, we're the shock absorbers. We're the ones just making sure that the impact of change is palatable, but also smoothing that friction and solving problems to keep things steady. So the first step is creating a sense of urgency, but not urgency driven by fear, but grounded by reality. Logical analysis showed that traditional hierarchies are not able to meet the demands of modern healthcare. So emotional awareness highlights the true cost of maintaining the status quo for patients and staff. So this is where we come into play. So as change agents, as many of you may function as, we're going to illuminate the facts. Tell leaders what's really going on. The champion will begin to link these changes to higher purposes. And then we have the shock absorbers that will support the team in transforming pressure into progress rather than burnout. Ultimately, this phase will clarify our purpose. The next step is to build a guiding coalition. And this is where transformation either gains momentum or stalls out. Over time, traditional models become ineffective in value-based care. And I'm describing models that rely on a few decision makers at the top. Coordinated care requires more perspectives, more shared thinking, and collective action. And this is where our roles come back into play. So the change agents, we're going to pull people into the conversation. They'll identify who needs to be at the table and align those voices across departments. The champions are going to create a connection. They will make sure every stakeholder understands the purpose, not just the plan. And the shock absorbers. We're going to keep the coalition grounded, bridging the gap between the big picture and real-world workflow realities. So when we bring both influence and insight together, we'll build a team that thinks broadly, acts quickly, and lead change forward. Now, once you built your guiding coalition, the next step is to form a strategic vision. And this is where clear initiatives come into play. This is where we direct the rider, the rational side of change, because when directions isn't clear, as signaled here, we'll begin to fill in the gaps with doubt, scope creep, or just default back to what's familiar to us. The solution is not to create the solution is to create what I call a destination postcard. And it's a tangible picture of success that's clear, measurable, and emotionally meaningful. For example, instead of a vague goal of saying, we will improve population health by next year. Instead, we might say, by Q3, our interdisciplinary team aims to cut heart failure readmissions by 15% through a streamlined, single-point discharge process. And this is where the change agent role is to define the destination and make it specific, as mentioned earlier. And then the champion will bring it to life, connecting the outcomes to patients, stories, and frontline impact. And then lastly, the shock absorbers will translate that vision into practical daily steps so the team knows exactly what good looks like. And when we do that, we have given the rider a map and an elephant a reason to move. Next is enlisting the Army after the vision is clear. And this is where we shift from have to want to, because the transformation does not happen through compliance. It happens when people truly believe in the goal and choose to be a part of it. The change agent's job is to grow that network, begin building those connection points across departments, and getting people involved who brings different perspectives, not just different titles. And you may experience this if any of you have ever gone through an electronic medical record system change. I'm looking at the nods. This is where those super users come into play. That is a form of a volunteer army. They're going to champion this move and fuel the motivation, as well as transform the culture by everyday work back to the purpose. They help teams see how their daily efforts connect to the destination, and most importantly, to patient outcomes. Now, the shock absorbers, and I find myself in this category often, we support the movement as it spreads, helping new voices step up, smoothing friction, and creating space for others to lead. In the value-based care world, it requires exactly this kind of agile network. Volunteers who operate alongside, not beneath the formal hierarchy, because when people are trusted and included and inspired, you uncover leaders that you never even knew you had. Next, after you have built that momentum, the next step is to enable action by removing barriers. And this is where we shape that path, or as I like to say, shrink the change. Because when change feels too big and team freezes, the goal isn't to push harder. It's to make things right or identify the behaviors that makes it easiest to do. The change agent will identify what's getting in the way, whether it's an outdated system, whether it's unclear processes, or just too many competing priorities. The champion is going to help reframe that change. They're going to turn one overwhelming goal into small, meaningful wins. And then we have the shock absorbers, and this is where they're critical. They're the ones who will help the team test, tweak, and simplify those daily workflows so change feels doable. Instead of asking everyone to overhaul their entire process, start with one small behavior, one metric, and one clear action. Next is generating short-term wins. And this is the moment that proves change is working. Not every step, but the few that breaks decision paralysis. And this is where the change agent leads here by translating strategy into concrete actions. Here's what to do. Here's what success looks like. Next, it's about turning that strategy into visible impact. So we'll pick one or two moments that clearly show the new way works better. The champion is going to amplify these wins. They're going to be our cheerleaders, celebrating our progress, no matter how small, and connecting it back to the patient's story. Then we have the shock absorbers who will keep that momentum going by reinforcing what worked and helping the team build on it. Because when we see firsthand that a small change makes care better or easier, that's when the elephant stays moving forward. The next stage is sustaining acceleration. So here, this is where we generally start at the initial change. Over time, as we're implementing the process, this is where we find the areas that is not working. This is generally a critical junction point for many. And this is where most change efforts here fades fast and old habits begin to creep up. So this is where we'll need the champions the most. They're going to keep the energy high, reconnecting the team back to the purpose and helping them see how their daily actions link to bigger outcomes. And then the shock absorbers are going to help prevent relapse by quietly reinforcing new habits and troubleshooting friction before it spreads. So culture change does not happen at the beginning. It happens when new behaviors begin to become routine. Consistency and energy matters, while quiet reinforcements matters most. This is where change becomes a habit. Now, as a new way of working becomes normal, in most, if not all organizations, you're going to need both the management as well as the leadership networks. The management is going to handle the day-to-day operations, stability, as well as standard clinical functions. But the leadership network, these are going to be your team of volunteers that's constantly coming up with new ideas and solving coordination problems. So let's bring all of this together. No one here is responsible for the entire change management infrastructure. That's not the work of any single role or individual. The 8 steps of change are a shared framework, not a personal checklist. Most of you will enter at the beginning where urgency is clarified, and you'll become part of the story that moves change forward. You may not be designing, but you are the ones who make the work. You take the strategy and interpret it, apply it, and bring it to life. So as a change agent, driving clarity and moving things forward, or as a champion, advocating for peers and sustaining purpose when momentum slips, or as shock absorbers, steadying the team and buffering the impact of transition, you are all alongside this journey. So when we look at the pathway, this is our starting point where overworked teams, role ambiguity, and frontline staff is holding the infrastructure and system together. Over time, we have the 8 steps, and this is where change leadership and clarifies purpose, reduces ambiguity, and rebuilds the momentum. And then we finally land at the future state where nurses operate within balanced systems of shared accountability, adaptive leadership, and coordinated care. Change doesn't move forward because everyone knows the framework. It moves forward because people steps into roles intentionally, collectively, and with permission. And any questions? And here are my references. Thank you. All right, thank you, everybody.